Okay, good evening, everybody, and welcome. We're really pleased to have you joining us today. Before we begin, because we're running this on Teams, can you please make sure that you keep yourself on mute unless you're speaking to help us minimize all the background noise and to ensure that everybody can hear clearly. Please also feel free to use the chat function. I'm going to try and keep a good eye on it throughout the talks. And if you have any questions, we're going to go through our 4 speakers first, and then we'll have a question and answer session at the end. Apologies if we're not able to answer everybody's questions, but I hope you enjoy the talks. Okay, the first speaker we have today is Mr. Nikos Burbos, who's a consultant gynae oncology from Norfolk and Norwich Foundation Trust. He's been a gynae oncology consultant for more than 13 years and started using HIPEC in 2020. He's going to present on OV HIPEC 1 and subsequent trials, current practices, which primary ovarian cancers are eligible, and what is the evidence. So over to you, Nikos.
Good evening. Thank you very much for organizing the webinar, Christina, and Des, thanks for the invitation. These are my conflict of interest. So currently there is no evidence to support the use of HIPEC in routine practice for patients that undergo primary site reduction. However, there have been 3 randomized controlled trials on the role of the HIPEC at the time of surgery following neoadjuvant chemotherapy, and I'll briefly summarize the results. The first one, the OVPEC-1 trial. So these are the long-term follow-up. This is a study for patients that undergo surgery following neoadjuvant chemotherapy. They've had 3 cycles of neoadjuvant chemotherapy, and the patient had stage 3 disease. This study showed survival benefit in the group that underwent surgery plus HIPEC compared to surgery alone. A second study published later than the OVPEC-1 was the Korean study. This was a mixed group of patients with stage 3 and 4 disease and patients that they were undergoing primary site reduction and patients that they were undergoing interval site reduction. Overall, then the entire cohort, the study showed no survival benefit for the group that was receiving HIPEC. However, when they looked on the subgroups that was undergoing surgery following neoadjuvant chemotherapy, the patient that received HIPEC at the time of the surgery had a survival benefit. And the third study, this is a single institutional study performed in Spain. This study did not recruit the number of patients that they were planning because of financial issues, and because the results from OVPEC-1 were published. The study showed a trend towards a benefit on the group that was receiving HIPEC at the time of interval site reduction, but that was not statistically significant. So what did we learn from these 3 randomized trials is that the addition of HIPEC appears to improve the overall survival at the time of interval site reduction. And there was no difference in the quality of life, grade 3 and 4 complications, and there was no delay to receiving postoperative chemotherapy in the group that underwent HIPEC. However, I'm not going to go into detail, but there was reading the studies appears that there is no consensus about the dose of chemotherapy that should be used, the target temperature, and also the circulation time for this patient. An important parameter that when implementing the studies in clinical practice is how to select the patient. The first criteria for selecting patients that then should receive HIPEC is the histological subtype of the tumor. Most of the studies, the majority of the patients in the studies include they had high-grade serous tumors. There are very limited data on other epithelial subtypes, and this is one of the largest studies on the other epithelial subtypes and non-epithelial tumor. These are an international database from SOGI, the result of which were published in 2018, and it appeared that the use of HIPEC for mucinous tumor appears to improve the overall survival. There was also some benefit on endometrioid tumors, but the other subtypes where they didn't have enough numbers to draw firm conclusion. Another question when we select the patient is the number of neoadjuvant chemotherapy cycles that need to be given prior to planning the HIPEC. There is evidence that delayed cytoreductive surgery may affect survival. However, there are no data from randomized trials on the use of HIPEC and how many cycles of neoadjuvant chemotherapy should be given. There is only one published study that involves the data from the team at the Gemelli Institute, and what they found is that if the patient have surgery in HIPEC after 4 or more cycles, there is no difference in the progression-free survival compared to if the same treatment was done after less than 4 cycles. The stage of disease, the OVIPEC-1 study included patients with stage 3 disease. The Korean study included patients with stage 4 disease. I'm not going to go into details because I saw this is going to be addressed in one of the subsequent presentations. So an important selection criteria is the age of the patient. These are the median age from the different randomized trials. As you can see, most of the studies selected relatively young patients because it is uncertain if the age on its own is should be considered as a factor to select patients for surgery and HIPEC. There are data from, this is a database from North American centers that they were offering cytoreductive surgery and HIPEC for peritoneal malignancies, and they found that age greater than 65 is a predictor of major postoperative complications. In this group of patients, they found that age is a surrogate for physiological reserve and frailty scores. They don't have any significant value in this group of patients because less than 1% of the patients had a severe frailty score. However, data from the UK and Irish databases for peritoneal carcinomatosis of different primaries, when they use the HIPEC, they found that age does not appear to be an important factor. And one of the last criteria for selecting the patient is the renal function and the prediction of what the treatment is going to cause to the renal function. So the incidence of renal tract injury has been reported to be up to 23% in patients that they receive cisplatin, intraperitoneal cisplatin. And there are several factors that they are reported in the literature that they affect the risk, such as the dose of the cisplatin, the temperature, the intraoperative fluid losses, and the use of nephrotoxic agents. On the last metric, it's important to remember that with the results of ICON 8B study, a lot of centers are going to offer bevacizumab in patients that undergo neoadjuvant chemotherapy. Bevacizumab is a nephrotoxic agent, and use of cisplatin following bevacizumab should be it is important to consider that when using the HIPEC. The literature suggests that use of sodium thiosulfate at the time of the HIPEC and prophylactic IV magnesium reduce the risk of renal injury and should be considered. So to summarize on this brief presentation, the data from the randomized trials suggest that the addition of the HIPEC improves overall survival. However, the patient selection, it is difficult. There are not many available literature data, and the selection should be individualized. So thank you very much for listening.
Thank you so much, Nikos. That's an excellent summary of the current evidence. Next, I've got the joy of introducing Aslam Shiras, who is a consultant gynae-oncologist from Addenbrooke's University Hospital Foundation Trust in Cambridge. Aslam is a consultant gynecological oncologist. He's got an interest in maximal effort cytoreductive surgery for primary and recurrent ovarian cancer. So over to you, Aslam.
Just trying to share my screen and kind of struggling at the moment. There.
It's live. It's live.
Yeah,
just present a view now.
Yeah, perfect. Sorry for that. Hi. My name is Aslam. I'm one of the gynae-oncologists in Cambridge. So thanks for the opportunity to speak. So my talk is basically looking at HIPEC and its role in stage 4 ovarian cancer. So as Nikos mentioned in the previous talk, there have been quite a few quite high quality trials that have now published on the role of HIPEC in interval cytoreductive surgical patients with ovarian cancer. And the majority of these papers have shown a significant benefit in overall survival in the HIPEC group. And I think for a lot of us, I think its use in stage 3 cancers, I think, is beyond doubt, certainly in the interval setting. But while that is the case for stage 3 disease, I think there's still quite a few questions that need to be answered about HIPEC and in ovarian cancer. And we know the original trials from LIM did not demonstrate a benefit in the primary setting, but we eagerly await the OV HIPEC 2 results of HIPEC and its role in the primary setting. We also know that HIPEC certainly seems to have a more beneficial effect in certain subgroups of patients, and there were recent articles that showed a greater benefit in patients that are actually BRCA wild type, and that's quite important because we know that BRCA wild type patients, in comparison to those that have a BRCA alteration, have derive less benefit from maintenance chemotherapy. And I think as we move to this more personalized approach to oncological treatment, I think HIPEC will certainly have a role in that as well. And then one of the talks that comes on from myself will talk about its role in recurrent cancer. But just for this talk, I'd just like to focus on stage 4 disease. And like Nikos mentioned at the start, there's not a lot of evidence for HIPEC in the primary setting. And actually, there's not a lot of work that's been done specifically looking at HIPEC in the stage 4 setting either. And I think when you look at most of the papers, I think the papers that really stand out that you can actually draw some conclusions from is probably the LIM paper of 2022 and the Lee paper of 2023. So if we look at the LIM paper from 2022, so this was a randomized trial. It was quite an important trial in the HIPEC literature, as it corroborated the OV HIPEC 1 results, albeit using a slightly different regime or certainly dosage of chemotherapy at the time of HIPEC. But they also looked at 73 patients who had stage 4 disease. It's a bit difficult to comment on how they define stage 4 disease, as in their supplementary data, they just speak about either CTs, MRIs, or PET pre-op. And I think this is something that we have to consider perhaps when we come to the discussion, and certainly for the consensus statements. But they looked at 73 patients with stage 4 disease, of whom 45 of them ended up having interval surgery. and 19 of those patients had HIPEC. And while the main headline results from this trials was the fact that overall survival was nearly a year superior in the HIPEC group in the interval stage 3 setting, or in the overall population setting. When you look at the stage 4 population as well, there is seemingly a significant benefit, certainly that seems to favor the HIPEC group in stage 4 disease as well. And then when you go on to the follow-on paper, which was the Lee paper that was published a year later, which was also a Korean study, but this was a cohort study, but once again had quite important outcomes from HIPEC and ovarian cancer. It was run across 7 centers in Korea, and it was more specifically assessing interval surgery and HIPEC. Once again, the regime that they looked at varied from the Lim paper, but the cisplatin regime was certainly similar to that of what was used in OV-HIPEC-1. So meaningful comparisons probably could be made from that. And once again, that did corroborate the OV-HIPEC-1 and the Lim results. So in the interval setting, progression-free and overall survival was significantly better in the HIPEC group. But they looked at a larger number of patients with stage 4 disease, and they defined stage 4 disease on the basis of CT scans, as well as on the basis of the diagnostic laparoscopies that they tended to do pre-interval surgery. And of those stage 4 patients, nearly half of them, just over half of them received HIPEC. And when you look at their results as well, once again, even in the stage 4 setting, there is a benefit in progression-free survival as well as overall survival in the HIPEC group. And I think when you look at the Kaplan-Meier graphs that they publish, it's quite striking when you look at the divergence of the two graphs between the HIPEC group in red and the non-HIPEC group in blue. And what was also interesting was that they looked at their patients in terms of 4A and 4B disease as well. And this response for 4B disease was also maintained. So I think the results are quite interesting and quite compelling from the point of view of stage 4 disease. So when you look at the current guidelines and what they recommend, as you know, there's a lot of disparity across the globe in terms of who recommends what at the moment. And I think the NCCN guidelines are probably the most up-to-date in terms of keeping on top of evidence as it comes on. And right now, their recommendation is that HIPEC should certainly be considered in the stage 3 setting. And what was interesting was that in the most recent update, even in the stage 4 setting, where the disease site, so for example, if a pleural effusion or a cardiophrenic node had resolved, they suggested that those patients should also be considered for HIPEC. And then when you go to our more European guidelines as well as our BGCS guidelines, at the moment, HIPEC is not recommended, but I understand that in the upcoming ESGO revision that it would be recommended. And then when you look at other guideline things, the American Society once again recommends it as well. And when you look at the PISOGI consensus statements, this is something that we actually should be considering as routine. So there is a wide discrepancy and in terms of what perhaps we should offer our patients. And why is all of this important? Well, if you look at the majority of ovarian cancer cases that are diagnosed in the UK, 60% of our ovarian cancer workload is diagnosed at stage 3 or stage 4, and a significant number of these are stage 4 cases. And we know that stage 4 cases have a poor prognosis, and we talk about 5-year survivals of between 15 and 20%. So I think having something in our arsenal that would lead to better outcomes is something that we all should seriously consider. And we know that the commonest recurrence site for all ovarian cancers is the peritoneum. And it was interesting that the Lee paper actually mapped out where recurrences occurred in patients who didn't have HIPEC and patients who did. And it's quite remarkable that in the HIPEC group, you're looking at a nearly halving of peritoneal recurrences. And of course, none of this means that we are curing these patients. But I think it's important to look at this data as perhaps a means of controlling disease burden in patients that otherwise do not have a lot of options. So what should we do? Well, I think a lot of us agree now that in patients who cannot have primary surgery, who have stage 3 disease, that perhaps HIPEC should be incorporated into the interval surgical setting. And I think as a group from the BGCS, I think this is something that we should certainly focus on delivering nationally. I think at the moment, I think the evidence for stage 4 disease is still not compelling as it is for stage 3, but I think it's something that needs careful consideration and certainly something that we should look at from an MDT perspective on a case-by-case basis. And perhaps from the consensus statement point of view, perhaps the NCCN recommendation is probably something that we should look at, because it's quite pragmatic and quite a practical way of looking at HIPEC in this setting. And that's all really. Thank you.
Thank you. That's absolutely brilliant. Thank you. So we've had discussions on the evidence that we've currently got, and now what's the evidence for stage 4 disease. We're moving on to a presenter, Christine Ang, who's a consultant gynae-oncologist at Queen Elizabeth Hospital in Gateshead. He's going to be talking about HIPEC in ovarian cancer. What about recurrent disease? What is the UK surgical practice for recurrent ovarian cancer, and what is the evidence? Christine Ang has been a consultant gynae-oncologist based at the Northern Gynecological Oncology Centre in Gateshead since 2013 and a consultant since 2009, and are looking to introduce HIPEC into their practice, having been successful with a business case and a grant through the Northern Cancer Care and Research Society charity. So over to you, Christine Ang.
Thanks a lot, Christina. I'm going to turn off my camera. I turned it on to prove it was an AI, but I've got really dodgy signal. I'm going to turn that off. Just to say, the business case has been submitted. It hasn't actually been approved yet, but I'm hoping it will. So I'm just going to share my screen. Right. Okay.
I'll let you know when I can see it.
Yeah, thanks.
You're live, just presenter view.
Can you see that?
Done. Perfect.
Okay, right, I'm going to minimize that. Right, okay. So thanks everyone, and thank you, Des. So just going to cut to the chase. Talking about obviously recurrent disease and what we do and what is our evidence. Right, so right, this is now not moving. Okay, there we go. Okay, so what do we currently do as far as recurrent disease goes? Well, BGCS guidelines published last year say that we can consider secondary cytoreductive surgery in selected patients. And these are mainly patients who've relapsed at an interval known more than 6 months following first-line platinum-based treatment, those who've had no residual macroscopic disease after first-line cytoreductive surgery, and those who have little or no cytes at relapse should be fit enough, and if the disease is thought to be resectable. So these patients should be made aware that disease is incurable at relapse. And even if we achieve no macroscopic residual disease, they still will need systemic post-op treatment. So when we look at what ESGO says, well, ESGO pretty much says the same thing, is that in patients who are platinum sensitive, after first-line treatment, they should be assessed for secondary cytoreductive surgery. So when we look at the what evidence is available, so early retrospective data actually showed that achieving no macroscopic residual disease at secondary cytoreduction was associated with improved overall survival in patients with platinum-sensitive relapse, but there was a lot of heterogeneity amongst these studies. So we've got 3 basically randomized controlled trials, affectionately known as GOG 213, SOC1, and Desktop 3. So if we look at the 3 studies we have here, we obviously have 2 arms. We have a surgery and chemo arm and a chemo-only arm. Now, it's quite interesting because GOG 213 had no selection criteria for identifying ideal surgical candidates, and it was down to basically the investigator believing whether or not the disease was operable. And only 5% of these patients had peritoneal carcinomatosis. When you looked at the patient groups in SOC1 and Desktop 3, 40% had peritoneal carcinomatosis. SOC1 used an eye model for selection. So this is looking at fecal stage, residual disease at primary surgery, the length of the platinum-free interval, ECOG performance status C125, and presence of ascites. And desktop 3 use AGO scoring, which is ECOG, complete site reduction in primary surgery, absent or low volume ascites at relapse, in order to select these patients. Now, interestingly, GOG 213 and desktop 3 actually demonstrated opposing results. In desktop 3, the median overall survival was 53.7 months in the patients who had surgery and chemotherapy, versus 46 months in those who had chemo alone, and this was significant, whereas in GOG, it showed an overall survival of 14 months in patients who had chemotherapy alone. So obviously that was quite different. So what about the addition of HIPEC in women having cytoreductive surgery for recurrent disease? Well, what does BGCS say? They looked at one study that was available at the time of publication, and this was published, I think, June of last year, if I'm correct, which said that that study, which I'll talk about a little bit later, didn't support the use of HIPEC for platinum-sensitive recurrent disease following secondary cytoreduction. And the reason was that, and for that reason, HIPEC wasn't part of the international treatment guidelines for relapse disease. ESGO came out with recommendation 15.4 that said HIPEC is not recommended in following cytoreductive surgery for relapse disease. Okay, so let's look at the available evidence. We've got 2 more studies since the BGCS guidelines came out. So we've got Zavanovich in 2021. We've got horse and chipper trials that were published 1 month apart in late 2024. So let's look at these 3 studies then. So Zavanovich's study was a phase 2 study with 98 patients with recurrent high-grade epithelial ovarian cancer, platinum sensitive, so at least 6 months after completion of first-line platinum-based chemotherapy, randomly assigned intraoperatively after the surgeon confirmed that resectability would be down to 5 millimeters or less. No difference in progression-free or overall survival with the addition of HIPEC. And so that study concluded that there was no support for the use of HIPEC after secondary cytoreductive surgery. Then the Italian group published the horse trial in November 2024. This one was multi-center randomized phase 3, again in platinum-sensitive recurrent epithelial cancers. They had quite a few more patients. They had 167 this time. That was randomly assigned, 82 for secondary surgery with HIPEC and 85 to surgery alone. They used cisplatin at 75 milligrams per meter squared, so slightly different from the Zavanovich study, which used carboplatin. Now, these patients were assigned with randomly assigned at the time of surgery in cases where residual tumor was less than 2.5 millimeters. Their primary endpoint was progression-free survival. Median follow-up was 83 months. And the median progression-free survival is 25 months in the group that underwent surgery in HIPEC and 23 months in the groups that just had surgery alone. So that trial concluded that HIPEC didn't increase progression-free survival in those patients. And in terms of adverse outcomes, they're pretty much the same. And then there was a chipper trial that was published a month after that. So in December 24, this was multi-center randomized phase 3, again, looking at patients who are platinum sensitive. Now, this one was interesting because this was following 6 cycles. So surgery was following 6 cycles of platinum-based chemotherapy with or without bevacizumab. They had 415 patients, so quite a lot more. And again, randomly assigned 207 to HIPEC, 208 without HIPEC. And they, like the horse trial, used 75 milligrams of cisplatin per meter squared. Now, interestingly, they found a statistically significant improvement in overall survival of approximately 10 months. And so they concluded that adding HIPEC to cytoreductive surgery in platinum-sensitive disease would significantly improve overall survival. Now, in terms of complications, grade 3 or worse adverse events within 60 days was about double in the number of patients receiving HIPEC to those without, so it's 49 and 27%. And there were 3 deaths within 60 days, but all in patients who did not have HIPEC. So I've also just put this one in just so you're aware. This is a study design that was published looking at platinum-resistant ovarian cancer. This trial hasn't been published. The results haven't been published yet, but it's looking at the use of doxorubicin with mitomycin in HIPEC. So just to be aware that there is something lurking around out there. Okay, so if we put it all together, are there any meta-analyses? Well, there are 3. The first one, published in 2022, looked at 2 trials. Now, if you can see my mouse down here at the bottom, you can, if I'm waving my mouse, can you see my mouse? No, yeah, there's my mouse. Okay, yep, so looked at 2 studies, looked at the Zvinovich study and then a Spiliotis study in 2014. Now, the second study that was done in 2014 has been highly criticized in its methodology, and that's actually quite a nice response to that study by the authors of GOG 213. So I would suggest you read it, and it's basically it's torn that study apart, and there are a lot of concerns with that methodology. But this meta-analysis concluded that the use of HIPEC in the recurrent setting didn't have any survival advantage. Then there was a second meta-analysis that was published actually just this year, and it had 3 studies included, and it's the 3 studies that I've already mentioned down here, Chipper, Horse, and Zvinovich. And there was no difference with this one in either progression-free or overall survival with the addition of HIPEC, so no difference. And then there was a third meta-analysis that was also published this year that included 7 studies, and basically the pooled analysis showed that the addition of HIPEC in the recurrent setting was associated with a significant improvement in overall survival, but no difference in progression-free. Now, but what's very interesting is if you look at the studies, there are a whole mixture of things. There are retrospective case series, there are phase 2, there are phase 3 trials. They all look at platinum-sensitive disease. But if you look down here, you can see that the cytotoxic agents that have been used are all really quite different. So what studies were they? So this one, and this one are retrospective studies. Oh, and that one. This one is the questionable methodology one. And then you've got the 3 other randomized trials that I've mentioned earlier. So just a whistle-stop tour. That's my last slide. And that's the summary of the evidence available for recurrent disease. Thanks. And I'll try and stop sharing this. Great. Perfect. Okay, thank you.
Thank you so much, Chris. Really appreciated. That's excellent. And our last but not least speaker is Ellen Nailison, who's a gynae-oncology consultant in Bath since 2023. They started HIPEC in Bath in 2024 and have done 10 cases now. Ellen will be talking on to audit or not to audit. That is the question. Over to you, Ellen.
Thank you, Christina, and good evening, everyone. Yes, so I was asked to talk about whether we should audit HIPEC or not. And just like Hamlet, when he contemplates on the meaning of life and death, we should contemplate on the meaning of audit in the context of HIPEC. So I'm going to talk you through why should we audit, what does NICE recommend, what do other specialties do, what do other countries do, and then a few considerations and a conclusion. So why should we audit? So we want to know what are we trying to accomplish with an audit and how will we know that a change is an improvement. We want to make sure that we're maintaining and improving quality of care and ensuring that our services align with the best practice and national standards, such as NICE. We want to make sure that we identify areas where care can be enhanced. We want to do audits because we want to measure patient outcome and safety, and it should be a mandatory part of our accountability and professionalism. We also can do audit to improve our resource efficiency, and national audits can be used as a benchmark to compare different centres. Lastly, it's there to inform policy and research. And as we've heard from the other speakers, there is evidence, but not in all areas. So I think audit is a very important tool to make sure we're doing the right thing for our patients. So NICE guideline was published in March 21, cytoreductive surgery with hyperthermic intraoperative peritoneal chemotherapy for peritoneal carcinomatosis. So this includes, for example, colorectal and primary peritoneal cancer. So there they've got two statements. So the evidence on the safety of cytoreductive surgery with hyperthermic intraoperative peritoneal chemotherapy for peritoneal carcinomatosis shows frequent and serious but well-recognized complications, and the evidence on its efficacy is limited in quality. Therefore, this procedure should only be used with special arrangements for clinical governance, consent, audit, and/or research. They suggest some key performance indicators focusing on efficacy and safety, and they are like progression-free survival, disease-free survival, recurrence-free survival, overall survival, quality of life, and most of the studies use the postoperative functional assessment of cancer therapy. So every kind of specialty has their own quality of life questionnaire, and ours would be FACT-O. There is a website that you can link into, and you can use this quality of life questionnaire. And then you've got the ERTOC quality of life questionnaire. And the other outcomes that are recommended are the safety outcomes, such as perioperative mortality within the first 30 days, intraoperative and postoperative hemorrhage, anastomotic leaks, sepsis, pain, stoma rate, readmission to an intensive care unit, and need for further surgery. Now, what do other specialties and countries do? So I did a little bit of an ask around the world, and I understand that the Netherlands has a CRS HIPEC quality registry that has been in place since 2019. And Marcus Rijken, who is a colleague of Willemien van Driel, said they obviously include all their patients in the OV-HIPEC-2 study at the moment, but there is no kind of separate like national audit for ovarian cancer HIPEC. In France, there is the RENAPE observational registry that started in 2010, and they register all peritoneal malignancies in there, including HIPEC and BIPEC. In Italy, thank you, Alessandra Ferroni, there is the ONCO team, so the Italian Peritoneal Surface Malignancy ONCO team, where all the CRS and HIPEC is registered. In Korea, all HIPEC is done as part of clinical trials, so no national audits. And in the United States, there was a collaborative database that ran from 2000 to 2017 that included data from 12 institutions, the big institutions. So I think in the case of ovarian cancer and HIPEC, I think to have an idea of surgical complexity, it would be really good to include like an additional KPIs such as peritoneal cancer index and the completeness of cytoreductive score, as that will in its own have influence on your progression-free and overall survival. Also, I think we should look at like postoperative ileus, acute kidney injury, and GI fistulas. In an interesting remark from Christina was, could we have a database that also acts as a standardized operation note, and then you can upload it to your EPR? I thought that was brilliant. Do the work once and collect data at the same time, standardize the way you kind of write down your op notes, and that could be kind of, I guess, uploaded to a national audit. And what platform of database should we use? And could this be a national audit, part of our national ovarian cancer audit? So I think audit is an integral tool to measure efficacy and safety in the introduction of a so-called new treatment, such as HIPEC, and national audit would allow comparison of centers. And we should agree on a set of key performance indicators based on the NICE guidelines, but also tailor to ovarian cancer and possibly part of NOCA. I think it would be an interesting and good addition. Thank you very much.
And thank you so much for that. That's brilliant. Thank you. Okay, so I can't end without introducing our additional experts who've joined us today. We are really honoured to welcome Willemien van Driel, who is internationally recognised for her pioneering work in ovarian cancer surgery and HIPEC, based in the Netherlands Cancer Institute. Willemien is best known for leading the OVI HIPEC 1 and OVI HIPEC 2 trials, which have shaped international practice around HIPEC and ovarian cancer. Additionally, we're very pleased to welcome Mr. Fahiz Mohammed, who's a consultant colorectal surgeon at the Peritoneal Malignancy Institute in Basingstoke. Mr. Mohammed is internationally recognised for cytoreductive surgery and hyperthermic intraperitoneal chemotherapy, particularly for the management of pseudomyxoma. Last but not least, probably doesn't require any introduction, but we have Mr. Des Barton, who's a consultant gynae-oncologist based at the Royal Marsden with subspecialty expertise in advanced ovarian cancer surgery, sarcoma and pelvic exenteration. So before we open to questions from everybody, would our speakers and our experts please, do you have any questions or anything that you want to raise for discussion? Any particular areas that you've noticed of controversy?
I'm going to ask you, Willemien, who've got so much experience in this, to comment on what's being said, and this is all part and parcel of our generating a consensus statement, which is not something the BGS has done a lot of, but we feel more and more it's part of what we should do to inform our colleagues and I guess the public as well. Jen, welcome your thoughts.
Well, I think it was a very comprehensive overview, and I agree with everything what was said. I think for ovarian carcinoma, the 3 trials which we have, I think it's good to realize that 2 trials started with surgery and followed with chemotherapy, and those trials were negative, and the trial which was sort of positive started with chemotherapy and had their surgery after 6 cycles. And up until now, for the primary disease, we see the same thing that for primary CRS, there's no benefit of HIPEC yet, but for neoadjuvant setting, there is benefit of HIPEC. So we maybe there's some sort of selection for those patients who were treated with neoadjuvant chemotherapy, that those patients who responded, they get surgery plus HIPEC, and then HIPEC is beneficial. But if patients are chemotherapy naive, and of course, those who are not responsive to chemotherapy are included in the group of patients as well. So that may be a reason why there's a difference in benefit. So, well, we will see what the OVIPEC 2 brings, and the CHIPEC trial, which is a French trial, which include both primary CRS and interval CRS. And I think regarding the registry, I think it's very important to register what you do. In the Netherlands, we have a national clinical audit for all gynae cancers. So since 2014, all patients are registered in that obligatory registry. And we've looked at the results of HIPEC in this group of patients for 3 years now, and we did see the same beneficial effect of HIPEC. So apart from the complications and the time to reinitiate chemotherapy, I think it's which is not different from the HIPEC group and the non-HIPEC group. I think it's very, very important that you register what you do. Yeah, because then you can also learn from each other. In the Netherlands, we've got these so-called mirror sessions where we discuss our results with all the hospitals. And then you get to know what other centers do. And if they perform better, then you just learn from each other, which is those days where we have these mirror sessions are really quite fun. Learn from each other.
So that's brilliant to know what's happening in the Netherlands. What's your current practice with recurrent disease, since it seems that there is a trend towards benefit in those who have had neoadjuvant chemotherapy? Have you moved towards using it, or?
No, at the moment we don't use HIPEC for recurrent disease yet. No, I think that's, yeah. I think the trial which is missing is chemotherapy versus surgery plus HIPEC. We don't know what the benefits.
Desktop 3 versus neoadjuvant and HIPEC.
Yeah.
That would be a fun head-to-head.
Yeah.
And Fahiz, do you have any comments from the world of colorectal surgery and pseudomyxoma to add into?
Yeah. So, I mean, it's really interesting listening to the evidence and the discussions. I guess from colorectal peritoneal metastasis, if you draw some parallels, I mean, I know they're different diseases, but many of you will know there was a big randomized controlled trial, a French trial a few years ago called Protégé 7, comparing basically patients who had complete size reduction for colorectal peritoneal metastasis with HIPEC versus no HIPEC, with a half an hour of a high dose oxaliplatin, 460 milligrams per meter squared. And there was no difference in overall survival. But what surprised everyone, particularly medical oncologists, was that high quality surgery actually gives you pretty good results. So, your survival in both, median survival is about 42 months in both arms, better than anyone had really seen before. The HIPEC regimen probably was not the right one, the correct one to use, or the optimal one. So we've got a bit of work to do there. But I guess if you take it one step further, you've got to think, well, what is it that HIPEC you're expecting HIPEC to achieve? What can it do, and what can't it do? And in a systemic disease like colorectal cancer, if you've achieved a complete cytoreduction, there's no visible disease, then what you want to do is maintain that complete response within the abdomen for as long as possible. So there is increasing evidence now to say that if you give local regional treatment, intraperitoneal chemotherapy, that you can delay that recurrence or perhaps prevent it. And I guess what can you not expect it to do? Well, this idea that a single shot of heated intraperitoneal chemotherapy will then improve survival in patients who have a disease that's likely to recur systemically is probably you're expecting too much from your HIPEC treatment. And if you've had adequate cytoreduction and you've had a response to systemic treatment, then HIPEC isn't going to really make a difference there. So that's a slightly different spin on things, and designing trials to prove or disprove that is really tricky. But I think if you can establish a national database where you're auditing what you do, then you'll be way ahead of the game. Because I mean, it's got to be mandatory. It'll cost a bit of money. Everyone needs to collect what they're doing and be honest about what they're doing. But you'll establish what surgery is going on, and then you can build on top of that with whatever HIPEC regimen you want to use or you think may be useful depending on evolving evidence. So that those are my observations.
Thank you for that. I'm about to do a rookie mute mistake there. Do you have any sort of heads up from the excellent data that you've been collecting in Basingstoke that you found particularly useful to collect?
Now, I think if you're collecting the basic data, so I think you want to get an idea of your patient selection, because clearly that's important in this. If you're not selecting the right patients, your outcomes are not going to be optimal. Plus, it's very difficult to compare different groups. So if you refine your patient selection, so that's important. You need some way of capturing that. Then the surgery that you do, clearly you need some way to capture that accurately. What the disease extent was preoperatively on imaging, intraoperatively, whether there's any correlation between your preoperative imaging, what you find at surgery, if laparoscopy was helpful, and then clearly your perioperative care, complications, because that's going to have an impact on outcomes. So you need to look after these patients effectively, get them out of hospital, that failure to rescue can really impact on outcomes. So whatever you do, however brilliant your selection and surgery and your HIPEC regimen, you're not going to see that translating into survival benefits. And then, of course, I think the trouble we've had is that patients come to us from all over the country. So capturing accurately the systemic treatment they've had, either whether you call it neoadjuvant or adjuvant, depending on the sequencing of treatments, getting that accurately has been a challenge, because that's going to feed into looking at refining your patient selection, because now we're getting smarter at molecular subtyping. That will add an extra layer, because we may find through all of this that actually there will be a subgroup of patients with a particular molecular subtype, and whether that's primary, whether that's recurrent, who will benefit from HIPEC in addition to their optimal cytoreductive surgery, and then it may not be for everybody. So yeah, those are the things you need to think carefully about what you're going to collect, and try and future-proof it as much as you can. And
I guess it needs to be dynamic, so as we learn more, we can add more into it as well. Okay, so before I open to the floor, are there any more questions or comments from the panel? Got silence here. So we've had a few questions come through on the meeting chat, and then I'll open to the two people who've got their hands up. So one question from, apologies, I'm going to pronounce your name wrong. It's Yanakis, I believe. The question was, for recurrent disease, could we employ CHIP or scheme for patients who do not fit desktop 3 criteria, but have a very good response to chemo, leaving them with fully resectable disease after 6 cycles of chemo? Should this be part of UK guidelines with ongoing audit? Wilhelmine, do you have any thoughts on that?
Well, I think that was exactly the group of patients who, well, not quite, because the patients who would fit the desktop 3 criteria would also were also included in the HIPEC study. So I think if you to apply HIPEC for recurrent disease, then I'm not sure if you would only limit it to those who do not fit for the DEST 3, because why not for the patients who I think the problem here with the HIPEC study is that we lack the data of chemotherapy only versus chemotherapy plus surgery and HIPEC. That's the difficulty with the HIPEC. But well, the proof of the pudding is in the eating. So if you want to get experience and you want to see how this works in real life, then I think the only way that you can do it is to start with it and register it correctly. And after 1 or 2 years, have an idea on how the results are and if they're comparable with the study.
So we're looking at needing a 3-pronged study of chemo only in recurrence, chemotherapy, then HIPEC, then desktop 3. of essentially the primary versus neoadjuvant argument, but in the recurrent setting.
Yeah.
Excellent. And so there was an argument here saying, well, not an argument, but a comment saying that CRS plus HIPEC in recurrent ovarian cancer may increase PFS if patient selection is done correctly. What are your thoughts on that? Do we know how to select these patients correctly yet?
Well, I think the difference in PFS was not that big between the two arms. I think 5 and 6 months. So I think the concept of HIPEC is that it may delay the occurrence of peritoneal disease. That's what we saw when we reviewed the OVPEC-1 data with the radiology, with the CT scans. Then you see less peritoneal recurrences in the HIPEC arm compared to the non-HIPEC arm. And by delaying the peritoneal recurrences, you make patients more platinum sensitive. So you can give them additional systemic therapy, which eventually prolongs overall survival. I think that's the idea of HIPEC, that you delay the occurrence of peritoneal disease. And for patients with recurrent ovarian carcinoma, if they are already platinum insensitive, then I'm not sure if HIPEC would add anything. Because in my practice, I wouldn't operate on those patients, to be honest. And I think the difficulty is that which patients do you select? What is the right selection then for these patients if you want to prolong the PFS? I think that's something we don't know. We don't have the data for that.
Yeah, I agree.
And I think if you want to start with the HIPEC, then I would start with the primary setting and make sure that those centers who participate or who are performing this treatment get experience with the HIPEC in primary setting. And then the second step would be to start with the current setting.
Yeah. Excellent, thank you. Okay, so our first speaker or question from the floor is from John Butler. Can you unmute yourself?
Yes, hi. Great, hoping you hear me. A great meeting. Well, good to see everyone. So, I mean, a couple of points is there's clearly a lot of heterogeneity in ovarian cancer, and so I think any audit, it's vital that we look. If we think of high-grade serous, the HRD proficient have a different outcome to the HRD patients. So I think it's really important we think of tumor biology. The other thing that is vital is the big problem in the UK is a lack of access to high quality cytoreductive surgery. And HIPEC is really an adjunct to this. So I think that HIPEC is a great stimulus for people improving the performance of their surgery. But I think it's really important that we do look at the tumor biology of the different cases, because it may be that we are seeing actually the chipboard data is effective in a subgroup, but not in others. That's all. But great meeting. Thank you, everyone.
Thank you. Any thoughts on that?
Well, I think if you look at the HRD data and the BRCA data, then the analysis which were done are all post hoc, so they're more hypothesis generating than they're really already so firm that they should drive clinical practice, I think, in my opinion. And the patients who benefit most from HIPEC on these post hoc analysis are the ones who are wild type, BRCA wild type with an HRD profile or an HRP profile. So the BRCA patients, surprisingly, because we thought it would be otherwise, the other way around, the BRCA patients, they seem not to benefit as much as the other two categories. And why that is, well, maybe the BRCA patients are already so sensitive to chemotherapy that adding HIPEC may not be, may not do an extra thing. That could be, but I think it's very good to get more information on what's happening there. So we need more translational research for that.
Next question is from Yanis Kostopoulos. You unmute yourself. Hello.
Hello. Great meeting. Yeah, it's very nice to see very good friends and colleagues around the world. It's just two comments and slash a question. The first one is, in UCLA, we have been doing HIPEC for 1.5, almost 2 years now. And I remember when we tried to introduce that, it was tricky to convince the committees about introducing chemotherapy in theaters, but surprisingly, it was not difficult to convince them about stage 4. And the reason is because we have the data from the Korean study. I appreciate these small numbers there. The second is the simple logic that the vast majority is peritoneal recurrence. The third is, at that point, we have our internal retrospective data of 420 patients that we're about to publish now. Showing basically, if you intraperitoneally decide to reduce the patient, might do the same. Therefore, in our basically protocol, the question is whether you should operate in stage 4. And if you do operate for intraperitoneal clearance, why not offer the HIPEC? And I will welcome the opinion of extra people. The second comment is about the recurrent disease, as very nicely Chris presented in her tables. If you see the vast majority of the studies have some kind of mini HIPECs, are 75 milligrams and are for 60 minutes, most of them, one or other or both of them. None of them have followed the known, let's say, tested cisplatin 100 milligrams per square meter for 90 minutes. Maybe William like to run the HIPEC 3 based on that for recurrence. But I just welcome the opinion of people.
Well, I think regarding the stage 4, I completely agree that if you think of the concept why HIPEC would work, and if you can reach a complete site reduction in stage 4 patients, then you delay peritoneal recurrence, and again, you eventually will lead to a longer overall survival. We retrospectively analyzed the cardiophrenic lymph nodes in the OVPEC-1 data, and what we saw there is that the benefit is also visible if there are enlarged lymph nodes at the start. So if there's stage 4B, for stage 4A, I would be really interested in your data, because in stage 4A, there's peritoneal disease in the thoracic cavity, and I'm not sure if then HIPEC would be beneficial. I simply don't know, but my gut feeling says that it's probably beneficial for stage 4B, but for 4A, I'm doubting, because the peritoneal disease comes back in the lung as well, and then you don't do anything about that. So I would be yeah, and to run OVPEC 3, well, I think, and that's something which we have to deal with more and more. Unfortunately, to run surgical trials, it's becoming a nightmare, and that's mainly due to the rules and the regulations and CETIS. It's incredible. You just need, I think, 4 or 5 people just for the administrative work. So, and the money, and so I'm not sure if I will be the one who runs the OVPEC 3. I really have to think hard.
Thank you.
Thank you.
And we've got Janos Veliga from
Hi,
Birmingham.
Christina.
Hi.
Thank you, and thanks for the great presentation. So I'm from Birmingham. We've done 14, so we are in the very early phase of our learning curve. 2 points. One is that I really would like the BGCS to help and guide us when it comes to negotiating with the commissioners. So it's going to come that this fairly expensive kind of extra treatment will be questioned by the commissioners, and I truly hope that this venture will aid the centers who've been doing this technique, or the ones who would like to set it up with the negotiations. That's just the 1 point, and I'm not sure whether Presidenta is here today of the BGCS. So The second one is a little bit more serious, is that I do feel that the UK centres have been quite shy to share their surgical outcome data. I could see that when the BGCS, we have we came to conclusion about the ovarian cancer KPIs. We were unable to get the bound or surgical KPIs included. Okay, so, R0, R1 rate, mortality rate. So basically the ones you would like to collect yourself. So is this, and this is for Mr. Barton, is this maybe a great opportunity to start nationally collecting data, not only on HIPEC, but also on patients who only receive cytoreductive surgery? So that's my question. Should we not take this opportunity? Everybody's so enthusiastic. We all want to share our outcomes. Why don't we share all ovarian cancer surgical outcomes? And we have to agree on, obviously, on the KPIs. Thank you.
Well, since you posed the question, in an ideal world, Janis, I think we'd want to capture all these data from the time of presentation to the number of cycles of chemotherapy, if they ever got chemotherapy, the delay from initial presentation to neoadjuvant chemotherapy. I don't know if John's still online, because John's worked a lot with this, and I know Andy Norden and NOCA have tried to address this. I think what we can say is that it's probably aspirational at the minute, but I think we're heading in the right direction. And we all talk about evidence-based practice, but you've just heard from Wilhelmine how hard it is to get evidence-based practice. But real-life data in terms of comprehensive database that everybody's obliged to put in, honestly, will, I think, be very informative. But as John has alluded to, a big issue is that patients aren't being treated, or aren't being treated in time, aren't being denied surgery and denied proper chemotherapy. It's alarming that the BGCS is running for maybe 40 years and we still haven't addressed this problem. John, do you want to comment on if I can invite you maybe to comment that Janis made about having a more comprehensive, all singing, all dancing national audit beyond what NOCA is trying to do?
Well, if you look at countries like Denmark and Sweden, where they've transformed or have very good outcomes, they have clinically led databases. And if you are not having high rates of complete cytoreduction, people look at why, and either you stop doing it or you have more help. But we have, as you're well aware, over 20 years, there are centres that are not performing well. Not their fault necessarily, but how things are set up. And the only way we can really do that is with high quality data. So, you're absolutely right. And I think the BGCS, I think it's obliged to have a role to improve it. But NOCA is one step in that direction, but it is about data collection and sharing of data. So, we've got a great group on this call now. We all just need to kind of fly a flag for better surgery and better order surgery.
Thank you.
I think, actually, I'm going to get Georgia to speak in a minute, but I think, Des, you really put your finger on a key point, that it's not going to be controversial as usual, but it's not all about the surgery. It's also about the pathway. I think countries like Australia, that's brought out their new cancer care pathway, where they've got their optimal care for ovarian cancer, where they actually define the interval from diagnosis to chemotherapy, and that interval between when you should be getting your surgery and when you should be getting back onto your chemotherapy after surgery. So really tightening up the pathway and making sure that we're not basically providing poor care just out with the surgery. I think it's really key that we pick that up as well. I don't know what your thoughts were on that.
Well, yes, I think trying to capture the whole patient journey is important, because we know delays to treatment, be it before or after surgery, or before after surgery plus HIPEC, is probably important, and we haven't captured that so much. If I can digress a little bit, Christina, with your permission, is to ask Fahis a question following on what Wilhelmine talked about, and that is HIPEC with the open chest. I seem to recall, Fahis, that in Basingstoke, if the diaphragm is opened and there's disease or maybe mucin spilled in, that you would give the HIPEC but leave the diaphragm open. In other words, to have the chemotherapy solution actually maybe be active inside the pleural cavity. Can you comment on maybe some other speakers have experience of this? Because certainly to date, when we've opened the diaphragm, we've closed it before we've given HIPEC. So we're not having a larger volume, and and diluting the concentration therefore of the cisplatin potentially. So I apologize if I've misunderstood and you don't do this, but my impression was that you didn't close the chest with before HIPEC was given.
Yeah, we don't. So if there's disease in the chest, or if we've opened the diaphragm, then yeah, we'll leave that open and let the chemotherapy wash. So basically, you get thoracoabdominal intraperitoneal chemotherapy, and there's some evidence to suggest the pharmacokinetics of intrathoracic chemotherapy is actually better than intraperitoneal chemotherapy in terms of the drug distribution, but also the concentrations within the pleural cavity. You get a higher concentration of drug for longer than you do in the intraperitoneal cavity. So yeah, you just need to let your anaesthetist know that that's what's happening, so that they're not struggling to ventilate the patient because they've got lungs full of fluid or a chest cavity full of fluid. But yeah, it's and then the drugs that you use, sometimes you can get a pneumonitis, but less so, more so with I mean, there are certain drugs that will give you that, but on the whole, patients tolerate it pretty well.
Georgia,
we tend to close the we tend to close the diaphragm, but even if with a closed diaphragm, we still see because we also place a tube in the cavity, and at the end of the HIPEC procedure, you see that there's also still, even with a closed diaphragm, you see fluid from the perfusate is in the chest. So yeah, the chest is definitely getting some chemotherapy as well.
Excellent. And Georgia, you had your hand up. I know you're working with the NOCA project. Would you be able to give us a bit more information on what data you already have collected but aren't able to present, and perhaps what you're looking to add?
Yeah, thank you for the amazing presentations. So I think from the National Ovarian Cancer Audit perspective, we've started reporting completeness of residual disease, but the completeness is very poor. And we think there are some data flow issues. So there are centers that, like I think Birmingham also has very poor completeness. And we know that these are centers that generally complete the residual disease. So we're working with the data managers and the NDRS to improve the completeness so that we are able to report meaningful surgical outcomes. I think for the HIPEC, we've tried to look at it, but the numbers are very small currently to report them per system. Thank you.
Looks like you're already on the case. Brilliant. And we've got Eva's got her hand up.
I was not planning to comment, but basically you mentioned the NOCA, and I just feel that there is an audit that has a lot of problems with the data collection. I mean, the way that the data are being collected, attributed to the trust, the diagnostic and not the treating trust, the way that is being pulled is just not good at all. I don't want to say my full opinion here, but I just think that is an audit that literally is leading us to completely the wrong conclusions because the data are wrong, just as simple as that.
I think the key thing is we need to try and improve the quality of the data that we're providing, but the difficulty is figuring out where they're pulling that data from.
The thing is that the data are being collected through Data Inside from different sources, that they are not necessarily the correct sources.
Georgia,
and we can discuss this outside this meeting because it's not directly relevant to the HIPEC, but the NOCA itself is just not
if you
the
can
correct,
send us an email,
not the correct way of actually discussing the quality of surgery. I work for the Christie, and we do like at least 200 cases of ovarian cancer a year, if not more. And if we go for IDSs, it's over 100, and still the NOCA is reporting us as having like 20 cases treated a year, which is ridiculous. Just anyway. But that's
Eva, if you can send us an email with your concerns, we would really appreciate that. Just get in touch. And we report by systems level, which are the units and the centers,
to try to overcome the problem with the trust versus centers. So yeah, thank you.
Thanks.
We got, so the purpose, oh, Wilhelmine, you've got your hand up.
Well, I was hooked because of the audit. I think what we do in the Netherlands, there are several biological registries, and I think the success of the registry is because we as doctors, we check the items which are entered in the survey in the database. So had a discussion that the data is not correct. Well, if it's incorrect, then you didn't fill in the data yourself. you filled the data incorrect. But the counter side is that it takes a lot of time. And so we as doctors, we check the data of all the gynae-onc patients who are entered in the database, which is a lot of work, but it does give you a lot of information back, and it really allows you to improve the way we deliver our care. And if you retract data from different sources, then I can imagine it's very difficult to be sure that the data are correct. That's and then you get discussions that people don't believe their results because they don't know which data are entered.
Very good point. And okay, so obviously the purpose of this discussion, so before we break, is to really come up with a consensus statement, which Mr. Barton and all the team have been working on through the Delphi process. That's going to be a BGCS statement on HIPEC. So I guess this is everybody's opportunity to say what they'd like to be involved and what they wouldn't like to be involved in it to influence the outcome of it. So nobody can say that they didn't have a say in the process going on. So before we close, is there any contentious points that have been raised or anything that you feel should definitely be included as a recommendation in the consensus statement, or things that shouldn't be? We've had a good point about funding, which I think is a work in progress for all of us, but I think that's an excellent point to secure that for our teams. Mr. Butler, one.
Yeah, John. Yeah, I mean, obviously things evolve with time, and guidelines are by definition historic documents. So I just think to as I know Des and others in the leadership of this will do, to say that, at this point in time, this is where we stand, and we are a reactive body that will respond to evidence. And I think it is just, I just really want to thank the leadership of this group for bringing people together. We work together, but guidelines are historic, but they show that people are thinking together and doing the best they can.
I don't know, we've had one ping through.
I think
there's some more.
Yes, well, I think we're almost going to come to close. You could talk all night, I guess, but it's really to say, so there's been 2 rounds of the Delphi process. So there is going to be a 3rd round of questions. But this is a work in progress. There'll be many iterations of this, which is evidence-based. So it's not the finished article. It's a start. And maybe in 2 years' time it'll be updated because there's new evidence. Maybe there'll be some preliminary data from OB HIPEC 2 or some other studies that will actually be informative. I would make a plea that this is in everybody's interest to buy into this and to share your data. I think they maybe offline, well, I mean, I could have a chat with you about the mirrors idea, which to me sounds mutually beneficial. You're looking inwards and looking outwards and benefit from each other. And the purpose of this is not to police what we do, but it's to make sure what we do is as good as it can be across the country. This is just a work in progress. So thank you everybody for participating. I hope within the next 2 weeks the third and final round of questions will go out. And then we'll work hard to get a consensus statement, all being well, sometime in the new year.
Muted. Thank you, Des, for organising this and the excellent selection of speakers and panelists, members. I think this has been a brilliant sort of summary of the evidence that we have for HIPEC now, and I think it's quite exciting looking forward. So if nobody's got any more questions, I will close the meeting. And Des has got one more.
No, I can't take the credit for this. The credit goes to Christina. So you've been very kind to say it's me, but actually you've been working tirelessly behind the scenes to get this organised. So I just want to say to everybody, it's not me or the steering group. It's a big team effort, and Christina was very much involved in bringing this to fruition. So many thanks, Christina.
Pleasure, absolute pleasure. It's been an exciting meeting to arrange, and I'm sure this will be a popular webinar to look back. The aim is to get this online, and Debbie is the brains behind that. But thank you all for coming. It's been really good. Thank you.
Bye, everybody.
Thank you very much.
Thank you. Bye.
Bye-bye. Bye-bye.
Bye.
Bye-bye. Bye-bye.
Bye.
Bye-bye.